I'm here with Deepinder Dhaliwal. Deepinder, I'm so happy. First of all, I'm always happy when I'm in your company, but I'm especially happy to talk about this topic because it's going to be a compelling conversation. I can already tell. So, the teaching has been that for reasons of antibiotic stewardship and for reasons of a lack of evidence and concerns about practicing voodoo, the teaching has been that there is no clinical evidence for using antibiotics preoperatively before cataract surgery. Confession, I do it anyway, okay? But I feel guilty about it. So you, of all things, speak in favor of this practice. Alleviate my guilt here.
Absolutely. First of all, thank you so much for inviting me to be part of this program. And I am speaking in favor of antibiotic prophylaxis before cataract surgery because we want the best outcome for our patients. We do not want them to get infected post-op. We do not want to use unnecessary agents, but we have to make sure or ensure to the best of our ability that they heal well without infection. Now, it's widely accepted that povidone iodine is a wonderful thing, right? So we use that to eradicate surface flora, but does it really eradicate all surface flora? The answer is no. We've studied povidone iodine versus fluoroquinolones and looking at time kill studies, and it turns out Bacillus and Serratia species are more effectively eradicated faster with fluoroquinolones as opposed to povidone iodine. Also, remember, when we do uncomplicated cataract surgery, a fairly high percentage of the time, there are organisms that are getting in to the anterior chamber. So we want some agent in the eye, sustained concentration of antibiotics in the safest way possible. And for me, that's using an antibiotic drop, namely a fluoroquinolone, for a high dose immediately pre-op. So Q15 minutes times 4, starting about an hour and a half pre-op, right when the patient gets to the holding area. So it's not 4 days ahead of time or 3 days ahead of time. I don't believe in that. It's right before surgery, high dose, and then immediately post-op, they use the fluoroquinolone as well, Q 2 hours that day, and then QID for a week. And that's it. So in that way, we're not going to encourage the emergence of resistant organisms because we're using short duration, high dose, we will kill bugs.
Okay, so you make a very, very good point and interesting evidence about povidone. I did not know that. I'm happy to have learned it. And so what you say completely makes sense. Having said that, just because something makes sense doesn't mean that it's true. Is there any evidence that doing what you speak of doing decreases the endophthalmitis rate post-operatively?
So Josh, you and I both know that to do a study like that, to show statistical significance in such a rare kind of complication, such as endophthalmitis, we would need tens of thousands of patients.
You would need more than tens of thousands, yeah. You would need a prohibitively large number.
So therefore, I don't have a study that can compare the two, but I can tell you when you look at the efficacy of just povidone iodine versus povidone iodine plus antibiotics, you see more surface kill, but also you see intraocular penetration of the topical antibiotics. Therefore, there's a sustained concentration in the eye, which is actually above the MIC 90 for the most common organisms, which, as we know, staph epidermidis.
So once more, you make a compelling case both for its use and for the impracticality that exists to demonstrate statistically that would be benefit, because these events are very, very
Right.
rare. One of the points that ID people make is that that's all well and fine. In the event that you don't have a decreased endophthalmitis rate, or even if you do, the one thing that you're going to know is if you get an endophthalmitis, you've now created one drug that you can't use.
So typically when we do the antibiotic prophylaxis, we're using fourth generation fluoroquinolone. When we're treating endophthalmitis, we're using different agents. So we're not using the same agent anyway. So I think that what bothers me more, I will tell you, Josh, is when people put vancomycin in the irrigating solution. I think that there's really no evidence for that, and I think vancomycin actually should be kind of a protected antibiotic, right, in terms of being a responsible physician. But in terms of a local use for short-term duration, high dosage of a topical fluoroquinolone, I think that it's perfectly acceptable. And as you said yourself, you do it yourself because you want the best outcome for your patients. So if it was your eye having cataract surgery, what would you want? I would want every organism possible to be eradicated first. I would want to just use topical drops. I don't use intracameral agents. I do not use intravitreal agents. I simply use excellent prophylaxis and effective postoperative management.
So although you and neither you nor I are likely to have ever set foot in a confessional, I feel so much better now having had this conversation about what I'm doing anyway. Deepinder, thank you very, very much for everything, and especially for your ever-present generosity of your time.
Thank you, Josh.